Fractionated Radiotherapy for Spine Tumors. I am Scott Soltis, Associate Professor of Radiation Oncology at Stanford University, and I am joined by Dr. Nadia Lak, Professor and Chair of the Department of Radiation Oncology at the Mayo Clinic. In this slide set, we'll look at the radiation tolerance of the spinal cord, and then look at the various locations where tumors of the spine can occur. So the intramedullary tumors, extramedullary tumors, the extradural tumors, and then tumors of the vertebral column. The primary consideration in treatment with radiotherapy for spinal tumors is the radiation tolerance of the spinal cord. Typically, the doses that we wish to deliver to the tumor are greater than the tolerance of the spinal cord. Here is a table of the risk of spinal cord myelopathy compared to the dose in conventional fractionation, which is 1.8 to 2 gray per day. And this is assuming that the full thickness of the spinal cord is irradiated at this dose. And you can see that the myelopathy risk with conventional doses of less than 50 gray over a treatment course is very low, but that rises quite quickly to over 50% at 70 gray. This is the standard shape of the sigmoidal response curve of normal structures at risk for radiation injury. For radiation-induced spinal cord myelopathy, the factors that increase the risk of injury include irradiation of the full thickness of the spinal cord as opposed to a partial volume receiving higher dose and the rest of the spinal cord receiving lower dose. A longer length of spinal cord or larger volume would increase the risk of injury. Doses higher than conventional fractionation of up to 2 gray per day would increase the risk of injury. A shorter time between fractions, such as more than one treatment per day, or a shorter time between treatment courses if a patient is getting repeat irradiation to the spinal cord, that would increase the risk of injury. And in considering re-irradiation, generally we want to have at least 6 months between treatment courses, and longer is preferable to allow time for the radiation repair to occur. And also radiation sensitizing systemic therapies would increase the risk of spinal cord injury. Before discussing specific treatments for various tumors, let's review the various radiotherapy techniques. The conventional radiotherapy is three-dimensional or 3D conformal treatment. This is typically done with one or more open, meaning unmodulated radiotherapy fields. I will show an example of that in the next slide. That's contrasted by IMRT, or intensity modulated radiotherapy, that also has multiple fields, but they are not open. The intensity of the beam, the amount of radiation dose, is modulated. Stereotactic radiosurgery also employs multiple radiotherapy fields. It can be modulated, but not always. But it has stereotactic guidance, so the accuracy is typically less than 1 millimeter. And if you perform stereotactic techniques over multiple days, that is fractionated stereotactic radiotherapy. The plans are identical to radiosurgery plans, but it's fractionated in smaller doses per day. Here is an example of a conventional 3D conformal radiotherapy field with the black denoting the total amount of dose delivered, black representing 100% of the dose and white representing 0. And you can see with an open field, it's either all or nothing. There is no gradient, there's no modulation of the beam. Here is an example of a 3D conformal radiotherapy treatment, in this case of a head and neck tumor, where your targets are in red, and then the subclinical volume that you want to treat to a lower dose is in brown. And with a conventional 3D technique with a field from the left side and one field from the right side, you would end up irradiating this entire volume to 100% of the dose. However, if you use multiple fields and within each field the intensity of the radiation is not 0 or 100%, but it's a gradient in between those, then you can achieve more complex shapes of the radiotherapy plan. Contrast that open 3D conformal radiotherapy field with this beam intensity from an IMRT plan. And you can see that any dose percent is achievable with IMRT. And with IMRT, you can sculpt the dose so that it conforms more directly to your target and spares tissues that are not at risk. In this case, such as the spinal cord, which does not receive 100% of the dose, as in the 3D conformal plan, but less than 65% of the dose. With that background, let's look at radiotherapy treatment for the various tumors that occur in the spinal region. First are the intramedullary tumors, the most common of which are astrocytomas and ependymomas, including myxopapillary ependymomas. Astrocytomas represent up to 45% of intramedullary tumors, with a higher percentage, up to 90% in pediatric patients. And the overall prognosis, similar to astrocytomas in the brain, is dependent on the histologic grade. Initial treatment often involves microsurgical resection for lower grade tumors, but the benefit is less clear for higher grade tumors similar to glioblastoma. Radiotherapy delays the time to progression and neurologic decline, and that ultimate prognosis depends on the age of the patient, the histologic grade, and neurologic function. Here is an example of a diffuse astrocytoma in the cervical spine, seen on the left by the sagittal T2 MRI. This was an H3K27M mutant midline glioma, according to the WHO 2016 classification. These are WHO grade 4. On the right, you can see an MRI 2 years after surgery, biopsy, and 54 gray of photon IMRT. Here's an example of a photon IMRT radiation dose plan prescribed at 54 gray, which is shown in red. A consideration in treatment of these patients is that they are at risk of pharyngitis, mucositis, esophagitis, and we generally try to limit the mucosal structures to less than 20 gray. In the bottom right, you can see that there is still some low dose irradiation of 5 gray in this example to the entire region anterior to your target volume. And this is typical of a photon radiation plan, which you would not see with a proton plan. The next histology of intramedullary tumors includes ependymoma, which behaves with a better prognosis and more benign than a astrocytoma. These are predominantly intramedullary, but a mix of papillary ependymoma, which is in the cauda equina, is extramedullary. Complete resection is more common than with astrocytomas, and that's really the goal of treatment. If a gross total resection is achieved for a spinal cord ependymoma, then no adjuvant radiotherapy is needed. For a myxopapillary ependymoma, it's generally considered that an en-bloc gross total resection is curative, and similarly, no adjuvant radiotherapy is recommended. Adjuvant radiotherapy is recommended, however, for higher grade histologies, for subtotal resection of a tumor, and it's controversial whether a piecemeal resection of a myxopapillary ependymoma while achieving gross total resection is beneficial. After piecemeal resection, local recurrence is up to 43%, and radiotherapy improves that to 10%, similar to rates of a GTR. Here is an example of a grade 2 ependymoma. In the left, you can see a sagittal T1 post-contrast MRI, which reveals a tumor at T11, 12. In the middle and on the right, you can see that there's a syrinx which extends superior and inferior from the enhancing tumor. For treatment of ependymoma, the radiotherapy fields are localized. Again, craniospinal radiation is not used unless there is dissemination of ependymoma throughout the CSF. Treatment dose is to the limit of the spinal cord, generally 45 to 54 gray in conventional fractionation, and local progression is the predominant pattern of failure. Typically, the GTV is the T1 post-contrast residual tumor and resection site. The CTV is a 1 to 2 centimeter margin, craniocaudal, and limited by the spinal canal, again, radially. For treatment of myxopapillary ependymoma, it's generally recommended to treat the meningeal sleeves laterally within the intervertebral foramina. Here's an example on the left of a post-operative MRI revealing subtotal resection and a residual syrinx. The middle and right image reveals the immediate and 1 month post-op MRI with enhancement both within the tumor bed but along the entire syrinx, which is suspicious for dissemination of tumor cells. With this concern for dissemination throughout the spinal cord, the entire spinal cord superior to the primary site was irradiated. This is a proton plan, which you can see the 50.4 gray isodose volume on the left in teal. And then the primary site receives a boost up to 54 gray, which is shown in pink. In contrast to the photon plan shown earlier, where the 5 gray volume irradiates a majority of the structures anterior to the spinal column, a proton plan minimizes the dose spread anteriorly. This patient did not have any of the typical side effects of irradiation to the anterior structures, including nausea and mucositis. Here's an example of an anaplastic ependymoma treated with a initial piecemeal resection. The radiation plan consisted of a volume which received 54 gray to the thecal sac inferior to the conus, and then a boost to 59.4 gray to the preoperative tumor volume within the thecal sac at the level of the sacrum. These higher doses are achievable because the cauda equina is generally thought to be more tolerant of radiation than the spinal cord. Let's move on to extramedullary tumors, which include meningioma and nerve sheath tumors. These are tumors that occur in the extramedullary intradural space. The treatment of spinal meningiomas typically parallels the treatment paradigm for intracranial meningiomas. Following a gross total resection, no adjuvant radiotherapy is recommended. If there is subtotal resection of tumor similar to intracranial meningiomas, these can be observed and treated at sign of progression or with immediate postoperative radiotherapy. The target volume is the residual or recurrent disease, as well as the preoperative extent of dural attachment of tumor. And then a minimal margin is given based on histology, 0 to 5 millimeters for a grade 1 or up to 2 centimeters for a higher grade meningioma. Typical doses, again, are limited by the radiation tolerance of the spinal cord, 50 to 54 gray. These doses are lower than what we would typically try to achieve for intracranial meningiomas, particularly for higher grade tumors. The next category of extramedullary intradural tumors include nerve sheath tumors. These are benign tumors that are historically managed surgically, but there is an increasing use of stereotactic radiosurgery, again paralleling the management of intracranial nerve sheath tumors. Radiotherapy is also used for multiply recurrent or higher grade tumors. The target is the residual or recurrent disease, and again with a margin based upon the potential extent of microscopic spread based on the histologic grade. For a grade 1 tumor, the typical dose is 45 to 54 gray, with higher doses for higher grade tumors. For malignant peripheral nerve sheath tumors, which are managed essentially like a sarcoma, one may consider pre-op radiotherapy of 50 gray and then a post-resection boost based on extent of residual disease. Here is an example on the top left of a preoperative schwannoma. Following surgery, there's residual disease as shown in the top right, and this was treated with a proton plan after the patient progressed. 50.4 gray was prescribed while minimizing dose to the spinal cord, which only received 45 gray in this plan. Extradural tumors include metastases to the vertebral column, as well as the primary tumors of chordoma, chondrosarcoma, osteosarcoma, and Ewing sarcoma. The most common of these certainly is vertebral body metastases. The bone and vertebral body are the most common site of metastatic spread of cancer. The most common cancers, and therefore the most common metastases, are breast, lung, and prostate. These can cause pain and neurologic dysfunction, and the treatment goals are to relieve those symptoms and maintain patient quality of life. Historically, radiotherapy for vertebral body metastases consisted of fractionated treatment whose goal was to palliate symptoms. However, there is an increasing role for higher dose regimens, including stereotactic radiosurgery, which can achieve a permanent long-term tumor control rather than short-term palliation. Here's an example of a conventional 3D radiotherapy plan on the left, with one treatment beam from the anterior and one from the posterior. With this beam arrangement, the prescribed dose is shown in green, and it's not immediately obvious, but the highest dose, which is shown in orange, is often not within the tumor. You can see the highest dose region is actually far anterior within the bowel of the patient. And with these older technology for treatment planning, doses typically needed to be fractionated or lowered, in this case 8 gray times 1. Contrast that to the stereotactic radiosurgery plan on the right, where again the prescribed dose is shown in green, but because this is more conformal to the tumor and spares the spinal cord and surrounding structures, greater doses are achievable, in this case 24 gray in 1 fraction, and this is expected to have more durable pain control and permanent tumor control. For conventional treatment of spine or bone metastases, the goal is palliation of pain, and lower dose regimens such as 8 gray in 1 is reasonable. Up to 40% of patients require retreatment of that site with these lower dose regimens. Longer fractionation can be more durable, up to 30 gray in 10 fractions, and that may be required for extra osseous extension or for neuropathic pain. With conventional treatment, the target is outlined, and then either a 1 to 2 centimeter expansion is targeted, or commonly an entire vertebral body above and below is treated to allow for matching of conventional radiotherapy fields in patients prone to getting new spine metastases adjacent to the treated site. Epidural spinal cord compression from tumor is a medical emergency. Any patient with a history of cancer who complains of back pain should be evaluated urgently. We know from a randomized trial that surgical decompression with a direct anterior technique is associated with superior neurologic outcomes than radiotherapy alone. The time to decompression or initiation of radiotherapy is the most important prognostic variable for maintenance or improvement in neurologic function, and ideally treatment should be initiated within 48 hours of the onset of weakness due to spinal cord compression. In those patients that are not surgical candidates, emergent radiotherapy can be given. The ambulatory status at the time of radiotherapy is prognostic if they will maintain or have improved ambulatory status. If they are ambulatory at the time of radiotherapy, up to 80% remain ambulatory. If significant motor weakness is present, then less than half remain ambulatory after radiotherapy, and few patients become ambulatory if paralyzed and treated within 48 hours. There are various fractionation schemes. Most common in the United States is 30 gray and 10 fractions, but there are data that suggests 8 gray and 1 has comparable initial relief of spinal cord compression, but with less durability than higher dose schemes. Moving on to primary bone tumors, these tend to be radioresistant and adjacent to the spinal cord, so they are best treated in areas of specialized care, which have modern radiotherapy treatment, as well as proton or particle therapy. These histologies include chordoma, chondrosarcoma, osteosarcoma, and Ewing sarcoma. Starting with chordoma, these tumors are notochordal remnants which occur most typically at the ends of the notochord. So these appear in the clivus and in the sacrococcygeal region. These are slowly growing cancers, but can be locally aggressive. They typically do not have metastases at the time of diagnosis, but if a chordoma locally recurs, then that's when metastatic disease typically occurs. The best outcomes occur following an en bloc or Innikin appropriate resection. If the resection is piecemeal or Innikin inappropriate, then the risk of local recurrence is upwards of 80%. In the radiotherapy treatment of chordoma, local control is associated with radiotherapy doses higher than 70 gray. If there's less volume of tumor, that has better local control. Radiotherapy at the time of initial surgery rather than at the time of recurrence has improved local control. Historically, these tumors have been treated with protons or heavy particles such as carbon ions. Modern photon planning with, for example, fractionated stereotactic radiotherapy can achieve these doses while minimizing dose to the spinal cord. Also, there's promising data with very high local control rates for a new paradigm of pre-resection radiotherapy, followed by surgery, and then more post-resection radiotherapy based on the extent of resection. So it may be that the standard paradigm of surgery first, followed by post-operative radiotherapy, may not be the best paradigm. These tumors are indolent, but can be locally aggressive, and it's not uncommon for tumors to recur 5 to 10 years later. For chordoma, the gross tumor volume is the residual disease, as well as the areas of normal tissue that were in contact with the tumor prior to resection. The margin is typically up to 1 centimeter and also includes the operative bed and incision sites. Oftentimes it's not possible to include the total operative bed, particularly at cervical spine or skull base, due to proximity to intracranial structures. And you typically try to achieve doses as high as you can go while respecting the normal tissue tolerance of the adjacent structures, but at least 70 and up to 80 gray to gross disease, and then 50 to 60 gray to subclinical disease. Here is an example of an extensive T12 to L3 chordoma shown on the left. It was causing cord compression, and the patient underwent resection, you can see the postoperative image on the right where the spinal cord has been decompressed, but given such a large tumor, there was still residual disease. This patient was treated with IMRT treatment plan. The axial and sagittal views of the plan are shown with the 80, 74, 56, and 45 gray isodose lines. The spinal cord and cauda are shown in light blue. And note that the plan brought the maximum dose to the spinal cord to 56 gray, which is higher than what we would typically use for non-chordoma histologies. And this is a higher risk treatment, but this is often necessary to try to maximize local tumor control. Moving on to chondrosarcoma, these tumors most commonly occur in the pelvis and femur, and within the spine, it's the thoracic spine. Local recurrence is nearly 100% with a subtotal resection, and we treat these similar to chordomas. However, unlike chordomas, these are not as radioresistant, and we can achieve very good local tumor control, upwards of 90% at 10 years, with doses approximately 70 gray. Similar to chordoma, the treatment for osteosarcoma includes surgery as well as chemotherapy, unlike for chordoma, where systemic options are limited. Radiotherapy is indicated after R1 resections if in the axial skeleton, and then if there's residual disease. Again, doses are greater than 70 gray for residual disease that's visible, and slightly lower for subclinical disease. Here's an example of a sacral osteosarcoma seen in axial and sagittal images. This patient received 76 gray to the gross disease, and then a lower dose to the areas of potential microscopic extension. Ewing sarcomas, unlike the other sarcomas we have discussed, are chemosensitive and radiosensitive. These undifferentiated small round blue cell tumors require surgery for diagnosis, but not for definitive tumor control. With chemotherapy and radiotherapy, local control at the primary site is over 95% for gross disease without surgery. For Ewing sarcoma, the pre-chemotherapy tumor volume with a margin is given a lower dose, 45 gray, and then a smaller volume is treated to a higher dose, up to 55.8 gray, if there is residual tumor following chemotherapy. In conclusion, fractionated radiotherapy is an integral component of the multidisciplinary treatment of benign and malignant tumors within the spinal column. Modern radiotherapy planning and treatment techniques have allowed for dose escalation to spinal tumors while minimizing the risk of normal structures, primarily the spinal cord. These modern radiotherapy techniques include IMRT, proton or other ion radiotherapy, as well as stereotactic radiosurgery or fractionated stereotactic radiotherapy. And with these modern radiotherapy techniques, improvement in patient outcomes may be realized with further research into the role of these new techniques and its integration with surgery and systemic treatments.